obviously Aaron Rodgers, he tore his Achilles, ruptured his Achilles in week 1. I want to just maybe kind of give you the floor as far as what was his procedure that he got, what would be the expected time of recovery, and we'll pull one stat for you. The amount of time between Aaron Rodgers' date of injury and his date of activation from injured reserve was 79 days. The date from Kevin Durant, the time that he tore his Achilles and then returned to play, was 552 days.
These are completely different.
We're looking at these windows. I mean, I'll give you the floor.
Look, that's a significantly different discussion, and one that I am reticent to have since I was involved intimately in one of those situations, and I know a lot that maybe the general public doesn't know, and I'm not about to share. So I'm not going to compare the two. That's for you to say. If that was the whole topic, we'd have to discuss a little bit differently on what we're going to talk about. Because here's the first thing I'm going to say. You mentioned Aaron Rodgers' outward communication of his psychology. Mm-hmm. There's no psychology on earth that is going to outrun biology and physics. So that you can believe whatever you want. I can believe that I'm going to be an NBA basketball player with KD. Okay, that doesn't matter. Like there's certain realities. So I don't really care what he believes. That's nothing. You can say whatever you want. There's people that believe the world is flat. There's people that believe nonsensical things. Yeah. So
there's guardrails. Biology are your guardrails.
Guardrails. Yeah. So I do want to suggest that just because someone believes they can accomplish something doesn't mean that that's legitimate or is even possible. Okay. That's the thing when it comes to this fandom. Even if you do have knowledge of sports medicine and performance, what happens inside an NFL facility, which we both have knowledge of, nobody knows. That's the thing. There was a fellow on the Dolphins that tore his Achilles last week or the week before, and people are making YouTube videos. I mean, what are you even talking about? You don't know anything about this person. You don't know what happened there. You don't know what happened after. So let's start with his surgeon is elite. I've had communication with the surgeon, not about this case, but he has done surgery on athletes that I have worked with. Now, I do think it's important that we recognize that surgeons typically don't have a role after they're done with surgery. That doesn't mean that they're not, they're just excommunicated, but they're not a primary decision maker in these elite situations. Once they do what they do, they leave it in the hands of someone else to not screw it up. Additionally, when it comes to information, there is still a absolute necessity that individuals' healthcare information is protected. So we're never going to know everything. And it's so when I communicate, I'm going to say, yes, I can communicate with Dr. Neil Elatrash if I need to. That's a fact. Okay. The understanding of the surgical procedure. Okay. Let's talk about that. This is not brand new. I believe that this type of surgery probably was started in 2018 or 19. Okay. So it's not old, but it's not, this isn't not an experimental procedure. And even if it was, this is an elite surgeon on an elite athlete. 41 years old, that does make a difference, but this is still one of the greatest of all time. So part of that like a 41-year-old that's the greatest of all time is still in this elite category. Now, I think it's also important to recognize let's start with where the rupture was. Because this procedure has varying levels of utility. You can try to do it, but it is most useful when the tear is in the middle. Using the Speedbridge, which is what this technique is. It's called.
That's the newer surgery.
So here's the Achilles, and Dr. Neil hasn't done anything yet. Okay. Over here is my foot, and over here is my knee. So the typical procedure would be to, bring it, stitch it up, and you got to make sure the length is proper. And then you go about, and I'll get to the rehab protocol. Right now, we're just talking about the surgery.
Yeah.
In this case, the Speedbridge puts 2 stitches through the Achilles here because it's healthy here at the bone.
Right.
And it attaches here. So you see it's anchored here on the heel. And it approximates this way. So it's still getting sewn up in the middle, but now it's being anchored at the heel. Now, why would we do this? The science of tissue healing, tissue loading, rehab process is faster than what we're typically seeing in most protocols for surgery. Okay? Way back when, I guess it would be in the 80s, people that were not compliant with the ACL protocols, meaning they wouldn't wear the brace or they got better faster. And that's what drove the research to see faster loading. So this isn't a weird thing that sometimes science catches up.
When you say the protocols, when you say the protocols, I just want to be clear, that means
rehab. Rehab.
Okay, that's the rehab. That's what the doctor says, hey, this is how it should proceed.
The doctors, typically the message comes from the surgeon because they can do different things. But really, in elite situations, it's a round table. Because usually it's the physical therapist, and obviously I'm aggrandizing to my role, and I am not going to suggest that the way I interact is always the way it works. But yes, the piece of paper with the protocol typically comes from the surgeon. Gotcha. But that protocol is influenced by what therapists are saying as well.
Okay.
So now the value of anchoring at the heel is if you are silly in this early loading that we know is what the science is supporting, it's not just being held together here, it's being held together here so it doesn't pull apart. I'm all in on that. I'm all in. I believe that this is a very, very useful tool. However, I'm also going to suggest it has nothing to do with how the biology of my fingers heal. So whether I have the anchors or not, if I'm smart, this still takes time to become sturdy and dense. Right. So what the Speedbridge, in my opinion and my understanding, and how I've communicated with other surgeons about this process is that I'm all in because there's no downside to doing this. And if you take the wrong step, the anchors may protect you. But if you don't take the wrong step without the anchors, the biology here in the middle is still the same. So it still has to take the same amount of time for that area to heal. Now, there's a third component that kind of puts those two things together. Because the anchors give you this confidence and maybe psychology to load earlier, you're applying a more contemporary utility of science, and it's not weird. We've talked offline. I have multiple patients that are doing the same thing. Now, they're not NFL players, and the demands of agility and lateral movement and the unknown of getting smashed is not part of their world. But I have a gentleman that's squatting, 3 and 4 wheels 3 months after Achilles, because we're doing things that, again, I'm not beholden to a surgeon, which might seem weird to other therapists. But again, it's different relationships and different ways of working together. So I'm all in on the utility of this because it puts you into a more contemporary view of science.
Right.
And the protocol that is largely accepted with the Speedbridge is that you would get to a level where you can start to train, kind of recondition at 12 weeks. We're significantly earlier than 12 weeks here.
Right.
Okay. So that is not something that is easy to explain as, it's because of this. Because we don't know it. We don't know it. We don't see it.